Okay, so you've all had, I would imagine, some sort of an introduction to fractures. I think you've had a lecture on or tutorial on maybe the classification of fractures, fracture healing, the factors which are responsible for the healing of a bone. Okay, so remember, if you just talk about a fracture, so a fracture is a break in the continuity of a bone. Good, and I know you all know this. But just think for a moment. In order for a bone to be broken, let's say you fell and you broke your radius. Now, in order for the radius to be broken, there must be some injury, which could be mild, moderate, or severe, to the soft tissue adjacent to the bone. So it could be that the most significant one that you should think about is a vascular injury. So I'm sure you'll go through all the complications of fractures, and it's a very easy way. So what are the immediate complications of fractures? So what's the immediate thing that can happen if a bone breaks? It can damage the artery. It can damage the nerve. Okay, so that should always be the first thing that you should try to ascertain in the management of any fracture. Then, what are some of the things that might occur within 6, 7, 8, 9, 10, 11 hours after? Compartment syndrome, fat embolism syndrome, then you get infection, then you get all of the other complications, delayed union, non-union, malunion. So always try and find an easy way in everything that you do. Try and understand the principles. So all I'm adding today is what happens if, in addition to the broken bone, there is an open wound. So all of the things that you've learned so far, all I'm doing to that is just adding another dimension to this open fracture, this fracture. And when you hear of an open fracture, the one thing I wanted to think about, so all of these organisms now have very easy access to this bone. So the incidence now of infection rises to the top, as opposed to if it's a closed fracture, then the incidence of infection would be minimal. So everything that you've learned so far about fractures, all of those things are applicable. All I want you now to say, okay then, let me just add, there's an open fracture. What's the big deal with an open fracture? Well, we all know the issues with an infection anywhere in the body. So if you therefore hear that someone has an open fracture as opposed to someone having a closed fracture, you'll think, okay, I need to address this as quickly as possible because I do not want these organisms to multiply inside of this broken bone and in the surrounding soft tissue, because the body then may not be able to mount an adequate response. So the role of the physician is to recognize this and to institute all the appropriate management, all the appropriate tools that you have in how can I mitigate or prevent these bacteria from multiplying and producing all of those symptoms. That's it. In a nutshell, that is all that I can stop giving this lecture and you're supposed to know the principles. But we will go on. So let's, before we talk about type 1 and type 2, I'm going to go to You see this slide? That's what I want you to always ask yourself. So why do I need to know another classification? So you are bombarded with classifications. You know, it reminds me of whenever there's an issue in a country, whenever there's a problem in Jamaica, you know what you hear? Oh, let's form another organization. The government says, oh, you know what, let's form another group of people who are going to investigate this. Well, there must be a reason. So why do you need to know classification of open fractures? I've already just said to you about the instance of infection, but this is really all that it is. However, it depends on how significant the infection is, which will then cause a number of these adverse effects. So it's all related to the infection. So the more severe the open fracture, clearly, the worse is the clinical prognosis. And this is important, is the clinical prognosis, is what this infection will cause your patient. That's it. If it didn't cause any adverse effects, then you really didn't need to know how to treat an open fracture. So the reason why you need to know classification is because you need to be aware that the more severe the open fracture, the more severe the wound, the more severe the number of fragments, the more severe the damage to the periosteum, all of that will lead to a worse prognosis. So the infection can be worse, the incidence of non-union. Sometimes patients end up with an amputation, or an amputation is the preferred treatment, but all of that ends up in limb function. So orthopedics, if you think about orthopedics is about function. Think about it for a while. If you sprain your ankle and you went to the orthopedic surgeon, what is our goal? Our goal is to try to improve your function. So that's truly is what orthopedics is all about. The end point is, can we get our patients back to his or her pre-injury status? It's about function. So I need you to understand this particular slide, and then we can go back to the classification. So this is why you need to know about open fractures, because it will affect the ultimate function of your patient. Whether there's a non-union, whether there's a delayed union, whether the patient ends up with an amputation, whether the patient ends up with a useless limb, whether the patient has an infection, whether the patient has a deformity, and all of that equals limb function. So with that in mind, let's go back to these. So all of this these are just classifications. Nothing is etched in stone, but it's just to give you some sort of an idea. So if there's a small wound, but it's compound from within, meaning the fracture has created a little aperture in the skin, so the chances are there is probably minimal soft tissue compromise. There's possible minimal contamination of the wound. So the best one to have would be a type 1. Okay? So because the incidence of the infection would be less. The degree of comminution of the fragments would be less. The degree of stripping of the periosteum, and you do know that it's the periosteum that brings the blood supply to the bone. So if the periosteum is stripped, then you can see that the incidence of delayed union and non-union would be high. It's easy. So if we go to the second one, so the wound is now greater than 1 centimeter. Okay, so the incidence of infection is probably a little bit more. But let's come to these. So now we come to the type 3, which A, B, and C. And the type 3 injuries are usually all high energy injuries. By high energy injuries, I mean fall from a height, gunshot wounds, road traffic accidents. Now, walking in your home and slipping and falling is not really considered a high energy injury. Just as the elderly individuals, they walk at home, they slip on the rug, they would fall, they would break the hip. That's not considered high energy. And the reason for my mention high energy is because there may be, in addition to the open fracture, other injuries may occur to other systems in the body, and that's what I want you to remember. High energy injuries can result in spinal injuries, vascular injuries, respiratory injuries, meaning an hemothorax or pneumothorax. So that's what I want you to remember about the type 3 injuries. They are all high energy injuries. And once you see high energy, in your initial assessment of these patients, remember now the first thing that you should think about, the ATLS protocols. So high energy equals not only an open fracture, but injuries to other systems which are life-threatening. Okay, so now let's come back. So the type 3A, so what's the difference between the type 3A and the type 3B? Periosteal stripping. With periosteal stripping, so yes, there's a significant soft tissue loss with exposed bone, but if that part of the body which brings blood supply to the bone is not there, then the incidence of non-union, the incidence of infection is greater. So as you go 3A, 3B, all of the things that I just mentioned to you about infection, non-union, delayed union, the possibility of an infection, all of those things increase as you go from A to B. Now C, the difference with C is it's associated with a vascular injury. So C has A and B as well as C. So if you just remember the principles, so the principles are as you go from type 1, 2, 3, 4, 3, A, B, C. All I want you to say to yourself, okay, all of these adverse things are likely to happen. That's what I want you to say, so you can say it to your patient. So then you can advise your patient that the incidence of infection, the incidence of non-union, the incidence of delayed union, despite your probably best efforts, those things can occur. And once you share that bit of information with your patient from the very beginning, your patient then would be knowledgeable. So should a non-union occur, the patient then would not be very surprised. They may be disappointed, but not surprised. So just remember the principles. Now, as I said, type 3 open fractures are usually high energy trauma. What also should be put under type 3? Traumatic amputation and all farm injuries. So now, if someone fell into the barn and sustained a type 1 with a centimeter wound, that is automatically a type 3, simply because of the type of organisms which now will now enter into the wound. Tetanus toxoid, so the Clostridia species. So remember, if all farm injuries, it does not matter the size of the wound, must be considered type 3 injuries and treated accordingly. So this we already spoke about. Why is a classification necessary? So in order to be a good physician, and I'm using the word physician and not surgeon, surgeons should be good physicians. So being a good physician involves knowing how to take an excellent history. You cannot treat your patient effectively without taking a proper history and doing a thorough physical examination. Do not make a diagnosis based on an X-ray or an MRI scan. Those are simply radiological diagnoses. They are not clinical diagnosis. So you can look at somebody and say, this is a comminuted fracture is displaced. That's a radiological diagnosis. Did you take a proper history? No. So what are all the important aspects that you need to know which would affect the management of this fracture that you've looked at? Have you examined the patient? No. So how do you know whether the pulse is there? How do you know if the patient has a nerve injury? So please refrain from, when somebody coming, you looking at the X-ray. Try and not look at the X-rays. Leave that for last. Take a history, examine your patient. You are now like a detective. After your proper history, say to yourself, but I wonder what is happening to my patient. Okay, and then you put down 1, 2, and 3. Now you've done a proper physical examination. And then, so number 3, your third one, may now become number 1. That's what you should do. So X-rays, CT scans, MRI scans, all of those things, they are tools to be used by the physician and not the other way around. We think that the MRI scan must rule the physician. Absolutely not. You must learn to use the tools in order to help you manage effectively your patient. So always remember that they are tools. They will not make a clinical diagnosis. So please remember this. So the mechanism of injury, remember I just said high energy, low energy. High energy injury associated with other injuries in the body. So that goes without saying. Okay, the location of the injury. So since we are now really talking about musculoskeletal problems, and by that I mean fractures, so if the mechanism of injury involves, let's say, the joint, well, you do know the importance of the joint. So the joint has articular cartilage, which we cannot really fix. But if there is a step in the joint, we should try and restore the bone fragments as best as we possibly can, because of the incidence of post-traumatic osteoarthritis will increase dramatically. So having an intra-articular fracture, you know, we need to treat this as soon as possible, but we need to fix it anatomically. Okay. A fracture in the metaphysis of a long bone, what are the important things there? The metaphysis has cancellous bone, there's a larger surface area, better bone healing. That if it's in the diaphysis of the bone, a smaller surface area, and there's not much soft tissue. So knowing the location certainly gives you an idea as to, okay, are there any negative factors? Are there any positive factors? Will these fractures heal because of where they are? How quickly do I need to address them? The timing of the injury. So what is really important is the timing of the injury of an open fracture. So the prognosis of an open fracture is dependent on, I would say, 2 factors. Factor number 1, the administration of parenteral antibiotics. And what do I mean by that? Suppose someone has an open fracture, it doesn't matter. An open fracture is an open fracture. In a type C hospital, Now, the doctor there does not have, he may not even have an x-ray, or she may not have an x-ray. Certainly, there may not be a specialist there. So this patient has to be referred. What should that doctor do? What should be the least that that doctor should do, apart from splinting the limb and putting up an IV? Administer broad spectrum antibiotics, because it has been shown that if the antibiotics are administered within 3 hours of the injury, that is the single most important prognostic factor. The administration of broad spectrum prophylactic antibiotics within 3 hours of the injury, not 3 hours of arriving at a type A hospital, within 3 hours of the injury. So please remember that. And of course, we all know the importance of comorbid conditions, and you can rattle for all of these things to me. But I'm going to mention what is sometimes not always mentioned, sorry, and something that we don't always speak about: smoking. Smoking causes vasoconstriction, and smoking can delay the healing of a fracture. So please remember that when you're talking about comorbid conditions, smoking. So an excellent operation may be done, and the bone does not heal. And lo and behold, the surgeon then recognizes, but I never asked this patient whether or not he or she smokes. Lo and behold, every day they're smoking 2 packs of cigarette for the last 20 years. Bingo. That's the reason for the non-union. So in addition to knowing all about the asthma, hypertension, diabetes, cardiac issues, and renal, please remember about cigarette smoking. And of course, drug allergies. You know that if a patient is allergic to penicillin, then you have to now decide that you should not give them any antibiotics which have any sort of penicillin base. Or if you are going to do that, you should give them a test dose. Okay. So now, your physical examination. So your history says high energy trauma. Oh, this patient also has an open fracture of the tibia. So you are called because you're the orthopedic surgeon. Road traffic accident, but the patient has come in, has an open fracture of the forearm, open fracture of the femur, open fracture of the tibia. What should be your first thought, first action? Resuscitation of your patient. Resuscitation, life over limb, life over limb. So your ATLS protocol, that must always, always, always take priority. Life over limb. So please, before you say anything about the limb, you say, I need to identify and treat any life-threatening problems. Then you can go and address the limb. Okay. So now, let's say your patient is now stable. So you're now focusing your attention on the limb. Let's say an open fracture of the tibia, for example. Or it could be the femur. Or it could be the humerus. You remember I said to you, in the management of any patient, whether it's a closed and open fracture, the first thing that you need to ascertain, the vascular status of the limb. So that hasn't changed. So palpate the pulses distal to the injury. What's the other important thing? Is the neurological status intact? Because how can you hold some things in your hand if you have no sensation? How can you walk if you have an insensate foot? But you lose the limb if you haven't ascertained that there's no pulse. So pulse, neurology. Now, so what happens if you're unable to palpate the pulse? It could be due to all of these things which I have listed here. The vessel could be kinked, could be severed, could be spasm, could be thrombosis, could be edema or swelling. Leave compartment syndrome out for the time being. So that's what I wanted to see. Now, all right, so if it's kinked, now you don't really know. but you have to ascertain, you have to be able to palpate the pulse one way or the other, or to ascertain that there's blood flow distal to the injury. So what's the easiest way of sorting? What is the easiest problem? If the vessel is kinked, or it's kinked because there's a fracture which has created a bit of pressure, that can easily be solved just by straightening the limb. So in a multiple choice, that would be the first thing that you should say. I'm unable to palpate the pulse. It may be due to kinking. I will now just realign and I will palpate again. If it's due to kinking, you'll be able to palpate the pulse. Now, what happens if, so here I go, align the fracture. That should be the first thing that you just say. That should be the first thing that you should do. What happens if you've done that and you're unable to palpate the pulses? So now, do you have a Doppler? Okay, you do have a Doppler. You put the Doppler around. If there's any swelling around the ankle, you may not be able to palpate the pulse. So the Doppler will say, okay, life is wonderful. So what happens if you're still not able to palpate, you're not able to ascertain from the Doppler? Or it may be there, but it may be thready. What should you now do? An emergency vascular consult is required, and the surgeon needs a CT angiogram. So it is important that you know this. You align it, Doppler. If you don't have a Doppler, you send your patient to a center where at least they've got a Doppler. If the Doppler is not as bounded and as the other side, and you look at the tracing and the amplitudes are low, then you need a CT angiogram. This is extremely important in order to save that limb. Now, I've just put this, I'm going to go back to this slide. Compartment syndrome. And the statement I'd like to make about this. So can you have a compartment syndrome in a limb, or rather I should say in the area in which there is an open fracture? So let's say there's an open fracture of the tibia. Can you get a compartment syndrome? Of course you can get a compartment syndrome, because remember, it depends on which compartment is damaged by the open fracture. Because remember, the muscle is contained by this fascial envelope. So you can still get a compartment syndrome. So these are all things that one has to always think about. In medicine, we must always think about things. We must try not to have tunnel vision. So if we think about things, oh no, this is not a compartment syndrome, or this is an open fracture. You've thought about it and you said, okay, let me try and rule out a compartment syndrome. No, this is not a compartment syndrome. But if you have not even given it any thought at all, one day you'll miss a compartment syndrome. Now, so that's all I'm going to say on that matter. Now, the ankle brachial index. Can anybody tell me what is this ankle brachial index? I've seen 33 people, and somebody can give me some idea. It does not really matter whether you are incorrect. It really does not matter, but I need some sort of feedback. So Ashley Scott, can you tell me what you understand? Do you have any understanding at all of an ankle brachial index? Hello? I don't like speaking to. Yes. So yes, Miss Scott. Give me some idea. What is an ankle brachial index? What do you understand by that, or anything about an ankle brachial index?
It's when you compare the blood pressure on your ankle measure against the blood pressure in your arm.
So the pressure of the ankle, the pressure of the arm. Yes. And do you have any ideas to
why it's done?
What value? And
I've seen it on the ward, test for peripheral artery disease.
I didn't hear that one.
I've seen it on the ward when patients come in, they suspect them of PAD.
Peripheral artery disease. Perfect.
Yeah.
Excellent. Excellent. Okay. So now we are checking the boxes, right? So remember, you have now ensured that your patient's life, the patient is stable. You've identified the life and limb-threatening problems. You've now come to the limb. The limb will survive because the pulse is intact. You've checked that box. You've checked that the patient has some degree of sensation. You've checked those two boxes. Remember, a number of these things are done simultaneously. So now I want you to look at the wound. So look, inspect, look at the size. Any gross contamination, you can remove it. I do not need you in accident and emergency to go trying to traumatize the patient by removing 1,001 little pieces of dirt and grass. No. Anything that's obvious, okay, of course you can remove it. Avoid exploration of the wound in accident and emergency. It's not necessary because the patient will be taken to the operating theater. Low pressure irrigation with normal saline. And I'm specifying low pressure. You do not want to give forceful irrigation because all that will happen, you will now push some of the dirt either proximal or distal, making it now that the surgeon now will have to make a longer incision to go proximal and distal. So just low pressure irrigation to moisten the vital structures. So that's all that is required in accident and emergency. And after you've done that, clearly you need some sort of documentation so you can show it to the resident, to your peers, and to the attendant, to the consultant. So you take a photographic documentation. Swabs are not useful at that stage. So don't waste the money of the hospital by taking swabs because all you get back are a number of contaminants. Apply after you have moistened the wound with normal saline, a number of times, not forcefully. Apply a sterile gauze soaked with saline, and I put the one look technique. Do not take the dressing down until your patient has gone to the operating theater, because every time you remove the dressing, you are now exposing that wound to further bacteria. One look technique. You can reinforce the dressing, but do not remove the dressing. And of course, you will splint the limb to prevent further soft tissue damage and for comfort to your patient. Okay. This is extremely important, so I've just tried to make this slide as detailed as I possibly can, because this is something that everybody needs to know, whether or not the patient has an open fracture. If you have a wound, you need to know this. And what I found is that a lot of the medical students sometimes don't know this, simply because by the time they get to accident and emergency with the resident, this has already happened. So what are some of the guidelines? So it depends on three factors. Three things that you need to know. Complete or incomplete vaccination. Can that history be obtained? This is important. The date of the most recent vaccination and the severity of the wound. Okay, so these are the three things that you need to know. All right, so let's go to the next slide. So tetanus toxoid, 0.5 cc's of 0.5 ml is only needed, one, if you've ascertained that there's been complete vaccination, or if the last date was within 5 years. And, I should say, and all of those, and there's minimal contamination. So if there's complete vaccination, that's all you need. Within the last 5 years, that's all you need. If there's minimal contamination, that's all you need. Just tetanus toxin. Now, however, you'll need the combination of tetanus toxin and tetanus immune globulin, 250 to 500 international units. One, if you are unsure of individual being fully vaccinated, or if the date of the last vaccination is greater than 10 years, or if the wound is contaminated, or if it's a tetanus-prone wound. So that's easy. So just remember these things, and then you know I need to give both. One gives immediate protection, the other one is delayed. Okay. This slide is just one point I want to reinforce again. The infection rate is increased when antibiotics are delayed greater than 3 hours from the time of the injury. This is a significant point that I want you to remember. You do not have to wait until the patient gets to the type A hospital to give them antibiotics. Give it to them when they come in and they've got an open fracture. Let's give it to them before the patient goes to have x-ray, before the patient goes to have any of those things. Of course, remember what I said before. High energy, the ATLS protocol comes first because that's life over limb. So which antibiotics should be used? And I'm going to say this. It really depends on where you practice. If you practice in Canada, they're probably still using the first or second generation cephalosporin. What we found in Jamaica is that now we've gone on to the third generation cephalosporins. But what I want you to remember is, okay, so as the degree of contamination gets greater, dependent on the size of the wound, the degree of periosteal stripping. So again, infection. So just say to yourself, okay, clearly the threes, A and B and C, the incidence of greater rate of infection is greater. So you know what? I need to give broad spectrum antibiotics for the type 3s. Good. So give a cephalosporin and an aminoglycoside. Okay. Now, the reason a cephalosporin by itself may be adequate for type 1 and type 2 is because maybe the level of contamination is less. But again, remember an important statement. It is a judgment call by the doctor. So don't just, medicine is not something etched in stone. You look at this thing and you think, you know, okay, it's a small wound. It's delayed. I'm not sure what bugs. You know something? Err on the side of caution. Err on the side of caution. Give your patient broad spectrum antibiotics. You will lose absolutely nothing. Please remember this. Don't just say, oh, well, you know, I was taught that if it's a type 1 or type 2, minimal contamination, fine. That's in nice controlled settings. Look at where you practice, and that's what should dictate to you how you treat your patients. Still, we have to follow certain guidelines, global standards of care. Yes, we do know that. But as I said, in Canada, they may say, you're just going to use Ancef. We are not going to use it because our bugs are resistant even to some of the cephalosporins. So it's a judgment call, err on the side of caution. Now, the freshwater wound, this is just, I don't need you to commit this to memory. What I want you to say to yourself, okay, so in 5 years from now, somebody comes and said, I got an open fracture because, you know, I was diving somewhere and I got a wound in the water. I wanted to say, well, what did this man say to me 5 years before? He said, you know, I should use another drug, another antibiotic. So the fluoroquinolones, or the third generation cephalosporin. So if you then looked up, this is where I wanted, if you then said, somehow I remember there's a difference. Take your things, look up freshwater open fractures. Yes, fluoroquinolones. I have no idea what a fluoroquinolone is. Pick up the phone, call the pharmacist and say, I need to prescribe a fluoroquinolone. Can you tell me which one and what's the dosage? There we go. So that's what I want you to remember. Because you have too many things. So now, saltwater wounds, the same thing, doxycycline or a fluoroquinolone. Remember what I said about if a patient is allergic to penicillin, clindamycin, vancomycin should be used. Try not to use anything that has a penicillin base. Okay. So now the pulse is fine, neurology is fine, you've inspected the wound, removal of gross contamination, irrigated the wound, moist sterile dressing, one look technique, taking all the photographs, tetanus prophylaxis, broad spectrum antibiotics parenterally, you've splinted your limb, you're doing well. You're doing exceptionally well. Now your patient needs x-rays. And remember, in orthopedics, frontal and sagittal views, EP and lateral. Always remember this. And you'd like the joint above and the joint below. Pain management, because your patient is in a lot of pain, and your consent form. Now, as you go along in medical school, hopefully before you graduate, I want you to pay more and more attention to the consent form. Now, for anything, probably more for those of you who will do surgery, you need to know a lot about the consent forms. It is extremely, extremely important. It is not something that should be just done in 2 minutes by the most junior person on the team. Absolutely not. If it's not done by the consultant, it should be done by the senior resident. But the consultant should also have a discussion with his or her patient. So the next time you look at the consent form, what should it state? So the benefits of the proposed surgery, irrespective of what it is. Let's just say this patient has a fracture of the ankle. So the benefits of proposed surgery on the ankle, but it's an open reduction and internal fixation, includes 1, restoration. What's the end point? Restoration of full ranges of motion of the ankle, and to be pain-free. Okay, now that's what you're hoping. Now, that may not be in reality, but that's hopefully the benefit, or to decrease your patient's pain, and to, let's put it this way, improve the range of motion. That's number 1. The risk stroke complications of the proposed surgery include, but are not confined to, the following, and discussed with patient. You list all of them, all the possible complications. So I always start off with an infection, because when I make an incision, that can happen. So then I will then say to my patient, okay, depending on what type of surgery I'm doing, if I'm putting certain things, yes, you get prophylactic antibiotics. Also remember, now, if you're immunocompromised, if you're diabetic, if you have HIV, if you're on steroids, the incidence of infection will be greater in you. However, we will give you prophylactic antibiotics. So, but you go through deep vein thrombosis, okay, that's possible. Now, what can you do to minimize your patient from getting a clot? So when you say this, you see what it is that you can or will do. It is not saying that your patient cannot get any of these things. The reason why it is so extremely important to put down, even though something it is mild, because we have become a very litigious society. So, and the lawyers don't care how hard you work or I work. They really don't care. What they're interested in, oh, so, doc, did you explain to this patient that this can happen? Well, it's really not that common, you know, but there is a rare chance of this happening. Yeah. Did you mention it to the patient? No. So we are already in a bind, but we just have to do the best we can. Discuss with your patient, sit down, take the consent form seriously, explain, and the last sentence of my consent form says, I, signed by the patient, understand and accept the risks or complications of the surgery, and the patient signs. So this is just to give you a little synopsis of a consent form. So the next time, just make that part of your learning experience. Flip open the chart and look at the consent form and just see if it has those things that we just spoke about. Okay, so let's move on. I need somebody to tell me what's the difference between urgent and emergent. Daniel Drakes. Oh, there's another Daniel Roberts. So let's go with Miss Drakes. Can you give me some ideas to what's the difference between urgent and emergent?
Hi Doc, morning.
Morning.
Honestly, I've never thought there was something different until now, but I would
Okay.
guess I would
Hazard a guess.
that urgent is something requiring immediate attention, while I guess emergent could be something probably requiring surgery.
Yeah. Suppose I told you it's just the other way around. That emergent is immediate. Say, for example, someone with a type 3C. That's correct. So something that's immediate that you need to know. Okay, to save the person's limb, if there's a vascular injury, that is emergent. That must be done right now. Urgent can be done 24 hours. So that's the difference. Emergent is now, to save the limb right now. So that's the difference between urgent and emergent is of greater importance than urgent. Don't worry. This is all about fun. This is all about your learning, and you mustn't take all of these things seriously. And meaning, what I mean by this, for when I conduct tutorials, I say to people, you know what it is? Don't be afraid to say I'm not sure. Don't be afraid to hazard a guess, because this is how you learn. And don't forget, we were all medical students. We probably were not as bright as you were. So when you see all these consultants walking around, and then you say to yourself, but hold on. Maybe when they were in medical school, they didn't know half as much as I know. So don't let those things frighten you. You are the future, and what our role, believe me, what our role is to make you the very best that you can be in your life, is to give you the encouragement, to give you constructive criticism, but it's more about encouragement, to give you the opportunity to think, to give you the opportunity to express yourself without belittling you. No, you have to play your part. So that's what we are there for, to guide you along the way, to prod you, just like your parents, to kind of scold you along the way when things you're not playing your part. Scolding is not being rude. Please remember the two things. Be not into the rudeness, but you must not ever feel Oh, I don't want to see something because my peers will think of me as dumb. Don't worry about that. Because something I always say, the brightest person in medical school does not necessarily mean that that person will be the most successful person when everybody is finished. And when I'm talking about success, I'm not necessarily talking only about material things. So please remember, some people are just wonderful in medical school. They're very good at passing exams. They're very good at doing all of those things. When you're finished, then you'll find your little niche and you will excel. You will excel because guess what? Your attitude. So we all have capabilities. Good. Then there's motivation. So you may have two students with the same capabilities, with the same level of motivation. But you know what separates the two students now? A little word called attitude. So remember, as you go through life, it's all of those things. So you may soar, not because you're brighter than the other person. Your attitude, you have a better attitude to life, to work, to not believing that you know everything. It is your attitude. Okay, so let's move on. So now that you've done everything in accident and emergency, great. Your patient has this open fracture. So you need to do something, as I said, about the infection. You need to say, I need to get rid of the bugs. How can I get rid of these bugs? Or minimize how much of the bacteria are there. Okay. So the first goal of the surgery is reduce bacterial load. 1. 2. But the bones are broken. So you need to stabilize it. Okay. 3. Now, depending on the size of the wound, remember now, you need antibiotics. Now, in addition to giving parenteral antibiotics, if I put antibiotics locally, wouldn't that be something that's advantageous? And the answer to that is yes. Okay. But you also need skin coverage. And then the other point that I didn't put there, at some point the bone has to heal. Now, all of these things may not happen at the same time, but that's your plan. Your plan is decrease bacterial load. You know what? I need to stabilize the fracture. Now, there is a wound. So, okay, so am I just going to leave this large wound open? Well, that's not a wonderful idea. So, when we go in as an orthopedic surgeon, the plastic surgeons come in at the same time when we are dealing with these grade 3 wounds. So the plastic surgeon is there along with the orthopedic surgeon, and then they make a decision. Okay, so where are you going to put the external fixator? The orthopedic surgeon says, I want to put it there. The plastic surgeon will say, can you put it here? Because I need to come in a few days and cover the wound. That's joint management of plastics and orthopedics. So let's break it down a little bit. So patient is taken to the operating theater, pre-scrub. Of course. Don't you want to wash off all the dirt from outside that the patient has come in? So if you go to the operating, oh no, you know, guys, I'm not sure when you're going to go to the operating theater. But however, so what it is, so patients is anesthetized or given an epidural. So now we are not proceeding. So put on a gloves, take on a scrub brush, take some Hibitine, and you scrub and you clean the whole limb. So you are taking up all that excess dirt. Now the surgical team goes in and we scrub, and then we put on the gown and we do formal prepping and draping. Good. A tourniquet is applied, but it's not inflated. It is only inflated in the event that there's some sort of torrential bleeding, but it is just applied, but it's not inflated. So you start from outside and you go in. Remember now, at the end you want nice bleeding edges. So you'll just remove 1 millimeter from the skin edge because it may have been crushed from the injury. So you want a nice bleeding skin edge. You're not taking off a centimeter. No. Then we will extend the incision proximal and distal, so then we have access to the wound. And this is really important. Meticulous surgical debridement. So meticulous surgical debridement means you start from the outside and you go in. So nice skin edges, you turn over, you look at the subcutaneous tissue. If it has dirt, if it has paint, you excise it. Then we go further down, you look at the muscle. Okay, so is the muscle viable? So all of this is meticulous surgical debridement, all that I'm saying now to you. And the second important prognosis is, remember what I told you, the first one, the second prognosis in minimizing infection is meticulous surgical debridement. So the number one, antibiotics within 3 hours. Number two, meticulous surgical debridement. Those are the two things. Okay, so let's go into this a little bit more. So do not leave any soft tissue that is not viable. But that goes without saying, because if it's left, that soft tissue is a perfect nidus for infection. So why leave it? So let's look at muscle. Look at the color. Is it pink or is it kind of off-colored? What about the consistency? Is it nice and firm or is it soft? When you touch it with the diathermy, does it contract, or with the knife? When you cut it, does it bleed? So remember those 4 C's. So that's easy. Just remember those 4 C's. And all of those should be there. If it's not, then you're like, oh, well, I'm not sure this is viable. Is it part? If it's not viable, then excise it. Okay, so now you come to the bone fragments. Bone fragments, whether they are small or large, if they have no soft tissue attachments such as periosteum, they should be removed because they are dead now, because there's no periosteal attachment. After you've done all of those things, copious mechanical irrigation. No antibiotics are required. Normal saline and copious irrigation with normal saline. So now you've excised all of those things, so it's nice, healthy, bleeding tissue, copious irrigation. Again, avoid pulsatile lavage, because if the pressure is too great, it will just damage the cells in the muscle. So there's no need for all of that. Now that you have a nice, clean wound, this is the time that you should take a swab and send it for culture sensitivity, because that will be more in keeping with, should your patient become febrile 3 days later on the ward, the culture that's received from microbiology is more likely the bacteria that's causing your infection. Now, the final thing here is when muscle viability is inconclusive. So you're not sure, what should I do? Should I leave it? Should I remove it? Make a decision. Come back in 24 to 48 hours and do what's called a second look. And that's proper surgical management. So it's not that you've done something that somebody will say, did you forget to do something? No, a decision is made. We will be coming back in 24 to 48 hours to have another look at the soft tissue. And if it has no demarcated, I know what to do. The one thing I also want to say, what happens if the nerve is cut? So now, if the nerve is cut, I want you to tag the ends together and leave the ends of the suture long. Don't do a nice definitive repair. Now you'll say to me, well, why should you not do that? What was the mechanism of injury that has caused the damage to the nerve. Unless it is like a nice sharp, like a blade, which would then cause very little trauma to the nerve endings, then you may consider doing that. If not, then the nerve endings are probably crushed, but you would not see it when you're now going in. You've now done your nice repair and you think, oh, this is wonderful, I've done an excellent repair. In 3 weeks, 4 weeks, 5 weeks, 6 weeks, there's no return of function. You are now wondering why. You now look at the nerve, and what you found is a bulbous end. A neuroma has formed. A neuroma is scar tissue or fibrous tissue which has been formed because the nerve endings were crushed at the time of the injury and a neuroma had formed. So knowing that that is likely to happen, tap the ends of the nerve together so you can find it easily and they are not retracted. When you come back in, you know, excise the neuroma, and now the definitive repair is done. Okay. So remember I spoke about local antibiotic administration. So when is that? If a significantly contaminated wound with large soft tissue defects or large bony defects. And all we are saying, how can we minimize the risk of infection? How can we minimize the risk of infection? In addition to my patient getting parenteral antibiotics, why don't I give them local antibiotics locally so it will leach out, come out slowly out of the cement which has the antibiotics, and it's right there. It doesn't have to go anywhere. It's right in the bone, it's right in the soft tissue. So in these situations, it is prudent, it is advisable, and it is a treatment of choice to do that in addition to parenteral antibiotics. And the bottom, you don't have to remember all of those things. So what we do, polymethyl methacrylate is the bone cement, and to that we add vancomycin and tobramycin B. So you don't really need to know that. Okay, so now we've washed out the wounds and we are happy, we've taken the swab, we've done all of those things. So we need to stabilize the fragments, right? Okay, but I'm sure you know that you would not put a plate in an open wound because the incidence of infection is greater. So you're putting a plate across this open node. So that's a no-no. So what are your two options? An external fixator. Remember, external fixators were devised for the correct management of open fractures. So there's no hardware at the fracture site. Good. So they were stabilized. You can inspect the wound underwater. Flaps or plastic surgery could be performed with an external fixator. So err on the side of caution. So if it's a type 3B, an external fixator should be put on. Now, if it's a type 3A, judgment call again. It depends on where you are. Please remember this. It depends on where you are practicing. So don't just say, I read in the book that says all type 3As I can put an intramedullary nail. That is not a correct statement. It depends on where you are. If you look at the wound when a person is coming late, you know something? Would I lose anything by putting on an external fixator now? The answer is no. In a week, okay, there's no infection, everything looks good. You can take the patient back to the operating theater in a week with the plastic surgeon if he's then going to cover the wound, and you can put an intramedullary nail. So what I'm saying is all of this is a judgment call. Yes, which one would give you better stability long-term? The intramedullary nail. But that you can always do in a week or in 2 weeks. But you do not want to put an intramedullary nail and you run the risk of now having an infection involving the whole bone. So that's all I want to say to you here. Yes, so it said minimal contamination, but there must be soft tissue coverage in order to put the intramedullary nail. You can't put the nail and it's exposed. External fixator with a bone loss, significant contamination, multiple level fracture. Err on the side of caution. This again, I mentioned, it's a team approach between the orthopedic and the vascular and the plastic surgery services. Because the sooner the soft tissue coverage, the better is the healing, the better is the risk of an infection. So soft tissue coverage with well-vascularized soft tissue prevents late infection and non-union. Again, that goes without saying. So just remember, it's not just orthopedics anymore. It is a combination of orthopedics and plastics working together. And the sooner the flap can be covered, of course, the orthopedic surgeon should have done his or her best. Meticulous surgical debridement, which is the second most important thing, your antibiotics within three hours. All of those things have to come together. Okay, now this is something, so it's called vacuum assisted closure. What is all of this? So if there is a wound, a large wound, okay, so what can we do? Is there anything that can be done to make this wound smaller? Yes, you can put on this thing called a vac. What does it do? It removes all of this interstitial tissue by fluid. By removing it, it makes the wound smaller. So if it makes the wound smaller, the plastic surgeon may now decide, all I need is a skin graft. I don't need to put a fasciocutaneous flap. So the vac is a great friend of orthopedics and the plastic surgeon in decreasing the size of very large wounds. What it does not do, it does not sanitize the wound. It makes it smaller and it promotes granulation tissue. Okay, well, this I've said before. So for the best bone stabilization, for the definitive treatment, an intramedullary nail, a locked intramedullary nail. Good. So just briefly, what happens? So now you've done all of these things. You have done your meticulous surgical debridement. You have stabilized it, whether temporarily with an external fixator, and then converted an intramedullary nail, or it was a type 1 or type 2, and you thought, I'll put an intramedullary nail initially because I can cover the wound. Wonderful. So now I have a defect. There's no infection and everything is progressing nicely, but I have a defect. How large is this defect? So let's say the defect is over 4 centimeters. What are your options? Well, there's distraction osteogenesis or bone transport. You can do vascularized fibrillar graft. That's what the plastic surgeon, or some call the Masquelet technique. Masquelet technique involves, okay, so there is this bone cement that's put in, and it has to be put in a specialized manner. So when we go in, we make a little incision in the sheath that has now covered over the bone cement. We remove the bone cement without jeopardizing this nice sheath, which now goes from one end of the bone to the other end of the bone. And then we pack bone graft in that huge defect, and then it's closed back. The Masquelet technique, yes, it's wonderful. However, the amount of bone that is required costs a lot of money if you're filling a defect of 4 centimeters. So we have not really used it that much because it's too expensive for patients. What do we tend to use? I do bone transport. So the structural osteogenesis is, of all of these, which is the one that's best used for defects greater than 4 centimeters? The structural osteogenesis. Okay, so I'm coming to my last, I think, 2 slides. So limb salvage versus amputation. So I'm going to make a few statements. In the past, an amputation was considered as a salvage procedure, and it was done when an attempt to maintain the limb was not possible. I want you to change that thought process. So it must be, so somebody comes in a type 3B, they've got 6 centimeters of bone loss, they've got extensive soft tissue injuries. So now they may have tendon injuries. I may take 1 year. So bone transport, consolidation, all of those different things. At the end of the year, what is the function? So the ankle joint may be stiff, the knee joint may be stiff, they've lost their job because they haven't been able to work. They may get recurrent infections. And okay, so let's say at the end of a year or let's say now a year and 6 months. So now they have a limb, but how functional is that limb? And that's what I want you to remember. How functional is that limb? So how we looked at it is, which would give the better result? Performing early on an amputation and fitting the prosthesis, fitting the patient with a nice light prosthesis, which allows them to return to function, allows them to work, allows them to drive, allows them to walk, allows them to run. Now, okay, they may have lost that body part, but guess what? They would like to go back to work. They'll have a family. What happens to all of that? So how it's now looked at is, if what I can do will give a better result than an amputation or fitting them with a really lightweight prosthesis, then that's the treatment of choice. The answer to that is no. That after all of this length of time, I've preserved their limb, but their ankle is stiff, they walk with a limp, they may have recurrent effusions, then an amputation is the better choice. That should be the treatment of choice, not a salvage procedure. So that's what I want you to think about. And usually that decision is very hard to make because the patient may not want to use their limb. And it depends on a number of factors. Yes, it depends on the patient characteristics, the age, the comorbidity, the personality. It depends on the experience of the team to do the salvage procedure. So only at the university hospital can we do these major salvage procedures of doing bone transport and doing all of those things. So that's why we tend to see a lot of the patients come in after a period of time where the flappers fail, they've had a chronic infection. Now they come for us to resect more bone and for the plastic surgeon and myself to do all of these surgeries. It would have been nicer if we got them earlier, we could have given them a better result. So, limb salvage versus amputation. Salvage is no guarantee of functionality, and that's important. So, when you're going to do the salvage, the experience of the team, is the technology available at the hospital? If the technology is not available at the hospital, then don't struggle and do all of those things and end up by giving the patient a significantly suboptimal result because it's function. It is function. So that's the end of my presentation. Any questions? Or has everybody gone to sleep? I'm sure you have not gone to sleep. Is everybody okay? I am not hearing one word. Jessica Gay. Any questions?
Well, yeah, I was wondering, so limb salvage and amputation are not the same thing. Like limb salvage is like, what exactly is limb salvage? I'm really sorry.
I didn't hear that again. Will you ask me what is limb salvage?
Yeah.
You remember I said limb salvage, the patient comes in. So let me go back to this slide so you can understand this a little bit better. Let's see if I have this slide. So if a patient, you notice I said a mangled extremity. So a mangled extremity is the same thing like classifying it into type 3A or type 3B. That's a mangled extremity. It means the soft tissue is significantly damaged. The bone is significantly damaged. Yes, I may see but I can fix the bone with repeated surgical procedures. I can do it. Okay. The plastic surgeon can say, okay, I can put all these different flaps. Yes, it can be done. We can save the limb. But that's what it meant by salvage. I am trying to save the limb. But what is the end point of my saving the limb? So that's what it really, when a patient comes in, not with a straightforward, that's not salvage. If it comes in, let's say, okay, so the patient has a type 3C. You've gone in, you've repaired the vascular, so the vascular surgeons have come in. Okay, they've done their part. But look at the rest of the limb. The soft tissue is significantly compromised. The bone is significantly compromised. It takes many surgical procedures to save the limb. And that's really what I meant by saving the limb. Many of these patients, and if you ever get the opportunity to come to my Elizarov clinic, then you'll see what I'm talking about, limb salvage. Patients have had these surgical procedures done at peripheral hospitals. They may have had 3 or 4 surgeries. And finally, it now becomes infected. The ankle joint is stiff, the limb is shortened, and the bone has not healed. So now they are told they need to have an amputation. They get referred to my clinic. And I will sit with them and I will say to them, well, I can make sure I can resect the infected bone, I can do bone transport, and I can make that bone relatively healthy. I can work with the plastic surgeon and we can rotate as many flaps on your limb. But guess what? They've come to me after 2 years with a very stiff ankle. I can't change that ankle anymore. All I can do is to get rid of the infection and to cover it. What I am not taking into account, what is their function? So in order to give you length, 5 centimeters of length, and then remember it's 1 millimeter per day in increments of 0.25 millimeters. Once the length has been restored, it takes just as long for consolidation, which could easily be another 6 months. So you may have this frame on, it could be for 2 years. Now, at the end of all of that, what has happened? So the patient does not want an amputation. What should have been explained from the very beginning? Well, this is what all of this care involves. It will be 2 years. So most of them are, at that period of time, they've lost their job. Most have lost because they can't work, because they're in and out of hospital. So all we are seeing in situations is what I call mangled extremities, not just somebody is coming with a type 3A. No. In the situation where, okay, should we do an amputation or should we not do an amputation? And that's where the discussion is. In those situations, and how does one decide? And it has to be made by 2 senior people, not a resident. Should we do an amputation? Okay, so what are the pros and cons? And that's where that discussion comes up about the limb salvage. Is this limb so bad that it needs to be amputated? Or can we salvage the limb? And I now need to think about it and say, I can salvage the limb. Of course I can salvage the limb. But is that the correct thing to do for this patient? So it's not my ability, because I have the expertise to save the limb. Let's put it this way, to save the limb. But in saving the limb, what about the function? And if the function would be less than an amputation done properly, then an amputation should be offered to the patient. Is that a bit clearer?
Yes, thank you so much.
You're most welcome. So everybody is fine, and everybody will have a wonderful weekend, and everybody will try and have a wonderful Christmas as best as it can be. Why you guys sound so down? Is life that bad? Why nobody answers? I really don't like giving these lectures when I can't see people, you know. Anyway, are there any other questions? Because I have to have some other patients that I need to see. Are there any questions?
None from me, Doc. Thank you for the lecture and enjoy the rest of your day.
Okay. So I will say goodbye and have a great weekend, everybody. And take good care of yourselves. Try and remember, do some exercise. Whatever it is, dance in your room and sing and shout and do all of those wonderful things. All righty, take care. Bye now.
Morning. You guys having a session now?
Morning, Doc. No, Dr. Rose had just left up his slides. So we're finished with that session though.
All right. Everybody's here, or some people went missing?
Doc, you have to can you end this recording or else it will fuse the two